Hello. So this is going to be a bit of a whirlwind tour of what's new in geriatric psychiatry. So when we see an older patient with changes in their mental status, we often ask ourselves, is this a psychiatric condition? Could this be related to something physical? Could this be a primary cognitive disorder like a dementia? And often, of course, it's not just one of the above, but a combination of things because these different factors interact and are closely connected with each other. And many older patients have a mental health condition like depression, psychosis, anxiety, chronic medical conditions like vascular disease, or they may be frail, and are also showing signs of cognitive decline. So as a very kind of typical case that would provide an example, we have Mrs. T, an 80-year-old woman who was recently widowed. She is being treated for some vascular risk factors. She doesn't have a past psychiatric history. She presents as very anxious, especially in the mornings, very distressed, tearful. She's getting more forgetful. Her children are needing to come in and check up on her, drop off prepared meals. She's starting to fall. Her cognitive screening tests are starting to show some impairment. So does this woman have depression? Does she have dementia? Does she have both? Could this be part of the bereavement process? Did you start her on an antidepressant? Did you back off because of falls? So a very typical common case, but presenting some complexities. So this is an outline of the talk. I'm going to spend a fair bit of time on the first topic, on geriatric mental health and cognition, in part because I find it an interesting topic, and it's a big focus of the field. Then we'll briefly touch on depression and physical health, and then we'll finally get to the practical stuff, advances in treatment. There's been tons of literature over many years on depression and cognitive decline and risk of dementia. And both early and late onset depression have been studied. There's a question of whether early onset depression could be a risk factor for dementia, and also whether late onset depression could represent a prodrome, that some patients may not present with memory changes or cognitive changes at first, but they might have emotional changes. And there's even a recent study looking at related personality traits, so neuroticism, as a possible risk factor for dementia. There were two meta-analyses that look at just prospective studies, so kind of the best studies, and depression and dementia risk. And amazingly, they managed to be published in the same month, in May 2013. And if you look at least on the bottom line of the Dinitz column, so when they just included the studies that adjusted for covariates and confounding factors, the numbers are pretty similar. That someone with depression has about a 50% increased risk of developing Alzheimer's disease or all-cause dementia, and about 2 times the risk of developing vascular dementia. So that sounds important, but it doesn't really answer the question of early versus late onset, risk factor versus prodrome. And there have been several recent studies that try to parse that out. This one is a bit older, 2012. It's a retrospective cohort study by one of the major researchers in our field, Christine Yaffe. And they had data for over 40 years on this group of people. And they found that people with midlife depression had a slight increased risk for dementia, 20% higher risk. People with late life depression, they had a 70% increased risk. And it was only the late life depression that had an increased risk of Alzheimer's disease. So again, could some of these people be a prodrome for Alzheimer's disease? Gives a bit more backing to that hypothesis. But both midlife and late life symptoms had over a 3-fold increase in vascular dementia risk. And here is a MRI, axial, cut right across from someone's forehead of someone who might have vascular dementia. And we can kind of think of different ways that depression and vascular disease may interact. Depression can affect health behavior, medication compliance, smoking, physical activity. There also might be some commonalities in the pathophysiology of vascular disease and depression, involving the neuroendocrine systems and inflammatory systems. And someone with a stroke, whether it's clinical or subclinical, might have areas of the brain affected that involve regulation of emotion. So it kind of makes sense. A more recent study from the Netherlands looked at cognitive functioning in older adults who were depressed versus non-depressed. And of course, the people with depression didn't do as well in cognitive testing. But interestingly, it was only the patients with a first episode of depression late in life who did worse on memory testing. Again, raising the question, could some of these patients be presenting with a prodrome of Alzheimer's disease? And there's just a slide on comparing hippocampal volume of a patient with Alzheimer's disease and vascular dementia, and a normal brain. So the hippocampus highlighted in purple there is kind of little and shriveled on the right, and that's the memory center of the brain. So there's all this interest, all this research on depression and cognition, but we see lots of other psychiatric disorders, including psychosis. And we know in the younger population, there's tons of interest on cognitive development and schizophrenia. So what about late onset psychosis? So here, a group from Australia did cognitive testing on 19 patients with delusional disorder, and they found some significant cognitive impairment, some domains kind of reaching dementia levels. But what does this mean? Is it a result? Have these people had this cognitive impairment all their life? Could it be a result of their psychiatric condition? Could it be a dementia process? So there was one recent study that explored using cerebrospinal fluid biomarkers of Alzheimer's disease to try to tease out that differential diagnosis. So maybe a future direction for our field. So I'm going to touch on depression and physical health. I included the first study on the slide because it connects those three corners of the triangle I showed you guys before, mental health, physical health, and cognition. So vascular risk factors were associated with depression and cognitive decline in older African Americans. And then those second two studies listed are among several that link depression in late life to measures of frailty and the falls. And that interaction is independent of medication, but the risk of falls increase further with, when people are on psychotropics. So finally, getting to the practical stuff, treatment advances. So I'll start with pharmacotherapy, and I'll warn that some of this is not terribly exciting with medication advances. The good thing is that we're seeing some clinical trials designed for older people. And these are drug company-sponsored trials of some of the more fashionable psychotropics of today. And so the first two studies are of Cymbalta. This one is for late-life depression, 370 people over 65, an average age of 73. It was a nice long study done over 6 months. And the primary outcome was a very commonly used, well-accepted scale for depression at 12 weeks, and it was negative. So it was a negative study, but that didn't curb the authors' optimism, and they point to several positive secondary outcomes over the course of the study where the scale separated from placebo. So we'll see whether someone tries their luck at studying Cymbalta and depression in the future. Eli Lilly had a bit more luck studying Cymbalta for generalized anxiety in older adults. Here, a similar population, about 300 people over 65. It was a much more short-term study, 10 weeks, and flexible dosing of Cymbalta and placebo. And you can see that the group was about evenly split, the treatment group, between staying at 30 milligrams of Cymbalta, going up to 60 or to 90 milligrams. And both Cymbalta and the placebo group enjoyed nice reductions in their anxiety scale. But unlike the first study, Cymbalta consistently separates from placebo after 4 weeks, and that held true for measures of functioning, the global impression, so a bit more promising maybe. And the last clinical study was of Seroquel for generalized anxiety disorder, 450 people over 65. And interestingly, this was again flexible dosing, and they got to pretty high dosing. So the mean dose of Seroquel was 167 milligrams, and almost 40% of patients got up to 300 milligrams a day. So that's a lot of Seroquel even for a younger person with anxiety. The treatment group did similarly well it's the same scale and reductions in that scale compared to the Cymbalta trial, but the placebo group didn't do quite as well. So Seroquel separates quite convincingly and nicely from placebo in this study. But I'll caution that despite the positive studies in generalized anxiety, Seroquel was denied FDA approval for that indication because of the safety profile of atypical antipsychotics. So if we have time, I'm going to save the best for last. Treatment advances in psychosocial psychotherapies. And the one geriatric treatment study published in the American Journal of Psychiatry this year was on dietary coaching and patients with subsyndromal depressive symptoms. So if you think about it, we see lots of older patients who might not have a full major depressive episode, but they have some depressive symptoms and they seem to affect their quality of life. So this study kind of speaks to that population. And the paper was actually from a trial of another psychotherapy, problem-solving therapy, and this dietary coaching was for the control group. And the control group did just as well as the treatment group, 40 to 50% improvement in depressive symptoms, and the improvement was maintained over 2 years. So how could this be? How could this be as good as psychotherapy? Well, again, it touches on that physical and psychological connection that maybe those lifestyle changes and diet improvement did make a difference. But the authors point out that there was actually probably a fair bit of overlap between what was provided in the psychotherapy and the dietary coaching. There's the support, but also patients are setting goals, using problem solving to meet those goals. It can reinforce a sense of self-efficacy. So it gives us ideas of ways we can help our patients. There were a couple of recent studies looking at using psychotherapeutic treatments in more marginalized populations facing a lot of adversity. So if you look at the description of this program, it's similar to a lot of what we would offer in an outpatient mental health department. Care management by a clinician, stress reduction, education, behavioral activation, and they wanted to see whether this was helpful for patients with depression who were facing a lot of financial strain. And they found that it wasn't quite as helpful compared to patients not experiencing financial strain, but there was still meaningful improvement. I'm going to switch around order a little bit as we wrap up, but problem-solving therapy is a very practical short-term therapy that's often used in depression in older people. And the top study looked at using Skype to deliver it in homebound, low-income older adults and found it just as acceptable and helpful as in-person problem-solving therapy. And there we go, I can go back. So mindfulness has been a big trend in psychiatry, and a very prominent research group did a pilot study looking at a group of older adults with both generalized anxiety disorder and cognitive complaints, so possibly a hard group to treat, and they showed very promising results, both in anxiety symptoms, but also measures of cognition. So in summary, our understanding of late life psychiatric disorders and their relationship to neurocognitive disorders and chronic medical conditions continues to evolve. There are some recent clinical medication trials in older adults for depression and anxiety, and care delivery models integrate mental and physical health. They use practical and accessible psychotherapeutic interventions.